Okay, welcome to the deep dive. We've got these revision notes here all focused on one specific condition,
That's right.
and our plan is really to dig into this material, pull out the absolute must-know info, the high-yield
Yeah,
stuff,
exactly. Make it stick.
so you can properly understand and,
Yeah.
recall restless leg syndrome when it counts. Think of it as a bit of a shortcut to locking down RLS.
Yeah, we'll guide you through these notes, point out what's essential, how it all connects, hopefully make it, well, a bit less daunting for revision.
Right. So let's jump in. Restless leg syndrome, or RLS. What's the core definition we need to get straight from these notes?
Okay, fundamentally, the notes say it's a neurological disorder. The absolute key things are, one, this irresistible urge to move your legs. It's like you just have to.
A compulsion almost.
Yeah, and two, that urge comes with, well, really unpleasant feelings in the legs, uncomfortable sensations.
And the timing is a big part of it too, right?
Yeah.
That seems critical from the notes.
Oh, absolutely critical. The notes really stress that symptoms get worse when you're resting, sitting or lying down, especially in the evening or at night.
Okay.
And the flip side, the thing that helps diagnose it, getting up and moving. Movement makes it better, relieves the symptoms.
Which obviously then messes with sleep
Hugely.
and just generally impacts your quality of life, as the definition mentions.
Exactly. So getting that definition down is crucial. Urge plus sensation, worse at rest or evening, better with movement. That whole package is RLS according to this material. That's your starting block for thinking about diagnosis.
Got it. Okay, so what's actually causing it? What's going on under the hood? Let's talk etiology.
Well, the notes are clear that the precise cause isn't fully nailed down. It's likely some mix, genetic factors plus environmental stuff.
But they do point to a couple of key areas. Systems or like deficiencies?
Yes, definitely. The notes consistently bring up two main things. Disruptions in the dopaminergic system, that's the brain's dopamine pathways, vital for movement.
Right. Dopamine.
Yeah. And iron deficiency, problems with iron levels or how the body uses iron. These two seem to be major players.
Okay, and that leads into this idea of primary versus secondary RLS, doesn't it?
It does. The notes talk about idiopathic RLS, meaning we don't know the specific trigger. It just arises, often linked to those genetic factors and dopamine issues.
And then the secondary?
And then secondary RLS, which is where the RLS is happening because of some other underlying condition or factor.
Right, and the notes lists quite a few of those potential secondary causes. What are the main ones to flag?
Okay, so the big ones mentioned are pregnancy, chronic kidney disease, and iron deficiency itself. See iron popping up again.
Yeah.
Also, certain medications can trigger it. Deficiencies in things like folate, B12, or magnesium. Diabetes is on the list. Spinal cord problems, Parkinsonism.
You medications?
Yep, medication side effects, and lifestyle things too, actually. Caffeine, alcohol, even chocolate are mentioned. Sleep deprivation, obesity. These can apparently trigger or worsen secondary RLS.
Wow, okay. That's a broad list. And this secondary thing is super important for treatment, I guess.
This is probably one of the most practical high-yield points from these notes. If you can find a secondary cause like low iron or a medication and you treat that,
The RLS might just go away.
exactly, it might resolve completely. So identifying those potential underlying issues is absolutely critical when you're assessing someone. Big point for revision.
Makes total sense.
Yeah.
And some of those overlap with the risk factors mentioned in the notes too.
Yeah.
What makes someone more likely to get RLS?
Yeah, there's overlap. The main risk factors listed are having a family history of RLS that links back to the genetics of primary RLS.
Uh-huh.
Older age is a big one. And then those medical conditions again. Iron deficiency, chronic kidney disease, peripheral neuropathy. Pregnancy is listed as a risk factor too. And using certain meds, again, tying into the secondary causes.
So if you have a patient with these leg symptoms and they've got kidney disease or a strong family history, RLS should definitely be on your radar.
Precisely. Knowing these risk factors just helps you think about RLS earlier, helps build the picture.
Okay, let's get a bit more into the how. How do those dopamine and iron issues actually cause the RLS symptoms? What's the pathophysiology section say?
So the notes suggest that this altered dopamine function and the problems with iron metabolism, they basically lead to changes in how the brain sends signals.
Okay.
Specifically, it affects brain areas involved in controlling movement and processing sensations, motor control, and sensory pathways.
So the brain signals for leg movement and feeling are kind of misfiring or not regulated properly.
That's a good way to put it. It's like a dysregulation in those brain circuits, influenced by dopamine and iron levels, that results in that uncontrollable urge to move and those strange sensations in the legs. It's fundamentally a brain issue showing up in the limbs.
Right. Okay, so we know the definition, potential causes, the how, but those symptoms that urge the weird feelings, other things, can cause leg discomfort too.
Mm-hmm.
How do we differentiate RLS? This feels really important, the differential diagnosis section.
Absolutely vital, you're right. The notes really hammer home that you need a proper clinical evaluation to tell RLS apart from conditions that might seem similar at first glance.
So what are the main conditions we need to rule out or distinguish from?
Okay, the notes specifically mention peripheral neuropathy. That can cause odd leg sensations, but the type of sensation, and crucially the response to movement, is usually different from RLS.
Okay.
They also list akathisia, specifically neuroleptic-induced akathisia, which you can get from certain antipsychotic drugs that block dopamine. Now, this is interesting.
Because RLS involves dopamine problems too.
Exactly. So you have restlessness linked to dopamine in both, but the nature of the restlessness, the trigger, the drug, it's different, needs careful separation.
Makes sense. What?
Nocturnal leg cramps are mentioned, usually sharp, one-sided pain, often eased by stretching, quite different from the RLS urge and sensation. Simple positional discomfort, just feeling a bit awkward, relieved by a small shift, not needing proper movement like RLS. Myalgia, just general muscle ache, different quality.
And peripheral arterial disease, that's a good contrast, isn't it?
Yes, a classic one. The notes highlight that PAD causes leg pain or claudication that gets worse with exercise and better with rest. Remember, RLS is the opposite. Worse with rest, better with movement. That's a key distinction to remember.
Definitely. Any others on that list?
Yep. The notes also mention Parkinsonism, venous insufficiency. You might get swollen legs, skin changes, but not usually that classic RLS urge sensation pattern. And interestingly, ADHD in children, because restlessness in kids can sometimes be confused.
That's quite a minefield.
Yeah.
And you mentioned peripheral neuropathy earlier as both a risk factor and something to differentiate from. How do the notes square that?
Good catch. The implication in the notes seems to be that something like neuropathy, or maybe a nerve root issue like radiculopathy, can sometimes trigger or worsen RLS symptoms in someone who's already susceptible. So you have to figure out what symptoms are from the neuropathy itself, like numbness, maybe constant pain, versus the specific RLS symptoms, the urge, the pattern of worsening and relief that might be happening because of the neuropathy. It means you really need to listen carefully to the patient's description.
Right, so the neuropathy could be the secondary cause, but the RLS diagnosis still hinges on its unique symptom profile. Okay, let's talk numbers. Who actually gets this? Epidemiology.
Okay, the notes give a UK prevalence estimate of about 5 to 10%.
Wow, okay, that's actually quite common, not some rare thing.
No, definitely not rare. It can affect anyone, any age, but the notes do highlight it's much more common in middle-aged and older adults. The likelihood generally goes up with age, often kicking in after 40.
What about gender differences?
It's noted as being slightly more common in women overall, and there's a specific detail. Women over 35 apparently have double the prevalence compared to men. The notes suggest maybe pregnancy plays a role there. But in younger adults, it seems to affect men and women pretty equally. The notes also throw in a Western Europe prevalence figure, 1.9 to 4.6%, showing there's some regional variation too.
So the takeaway is, think older adults, particularly women over 35, but don't rule it out in anyone.
Exactly. Knowing the typical demographics helps focus your thinking.
Let's circle back to the symptoms then, pulling it all together. What are the clinical features? How do people actually describe this?
So again, the notes reiterate those core things, the irresistible urge to move, those really unpleasant sensations, often described quite vividly, like crawling, tingling, pulling, sometimes even an aching feeling deep inside the legs. And remember, worse at rest evening, better with movement.
And does it stay the same, or can it change over time?
Good question. The notes mention it can progress. Initially, maybe it's just a nighttime thing. But over time, symptoms can start showing up during the day, too, especially if you're sitting still for long periods.
Right.
That urge to move can become, well, almost unbearable for some people. And the sensation, it isn't always just uncomfortable. The notes say it can be described as actual significant pain sometimes.
Which explains why it has such a massive impact on people's lives.
Absolutely. It leads to chronic lack of sleep, lots of stress. The notes highlight that it can cause major physical and emotional difficulties, really hitting quality of life hard. It's definitely not just fidgety legs.
Okay, so if you're suspecting RLS based on all that,
Yeah.
how do you confirm it? What investigations do the notes recommend?
Right. This is key. The notes really emphasize that the diagnosis is mostly clinical. It comes down to the history, what the patient tells you, and a physical exam. There isn't like a single blood test or scan for RLS itself.
But there are specific criteria to check off.
Yes, the notes mention the IRL SSG 2014 diagnostic criteria. That's the International Restless Leg Syndrome Study Group. You need to know the essential criteria from the notes. These basically recap the definition, but as diagnostic points. The urge to move legs with those uncomfortable sensations, check. Symptoms worse during rest or inactivity, check. Relieved by movement, check. Worse in the evening or night, check. And crucially, the symptoms aren't better explained by something else.
Right, covers all the core elements. What about the supportive criteria? Things that add weight to the diagnosis.
Yeah, the supportive criteria listed are things that make RLS more likely, but you don't have to have them. They include things like seeing a good response if you try a dopamine-type medication. The presence of periodic limb movements, we need to talk about those. A family history of RLS. And the fact the patient isn't overwhelmingly sleepy during the day in a way that suggests a different sleep disorder. The notes also say to consider the pattern. Is it chronic, intermittent, and other factors like age, gender, pain level, where exactly the symptoms are, etc.
And when do actual tests come in then? Blood tests, scans?
You order tests mainly to look for those secondary causes or mimics we talked about, things that could be causing or pretending to be RLS.
Like the iron deficiency.
Exactly. So the notes list specific tests. Serum ferritin, that's key for checking iron stores. Renal function tests for kidney disease. Fasting blood glucose for diabetes. Magnesium, TSH for thyroid, vitamin B12, and folate levels.
Okay.
And if the physical exam suggests a nerve issue, like neuropathy or a trapped nerve, radiculopathy, then the notes say you might consider nerve tests like EMG and nerve conduction studies.
So investigations are really about ruling out underlying problems. You mentioned periodic limb movements, PLMD. The notes bring that up here too.
Yes, they do. Periodic limb movement disorder, PLMD. It often comes up with RLS because they can happen together, but they are different things. PLMD involves involuntary repetitive movements of the limbs, usually legs, mainly happening during sleep.
So the big difference is voluntary versus involuntary.
That's the core distinction. In RLS, you choose to move your legs to get relief from the feeling. In PLMD, the movements just happen involuntarily while you're asleep. PLMD can also mess up sleep and cause daytime tiredness, like RLS. The notes mention management can overlap, but knowing that voluntary and involuntary difference is key.
Got it. Diagnosis is clinical. Tests check for secondary causes. So how do we actually help people manage RLS once diagnosed?
The notes lay out a kind of step-by-step approach, starting with non-pharmacological stuff. Things you can do without drugs.
Like what sort of things?
Simple things first. Walking, stretching, massaging the legs, things you can do right when the symptoms hit. And critically, treating any underlying iron deficiency is mentioned again here, showing just how important that is.
Right.
Then lifestyle adjustments. Avoiding caffeine close to bedtime, maybe cutting back on alcohol and caffeine generally, regular moderate exercise, warm baths before bed might help. Stopping smoking is advised. And during an actual episode, besides moving, things like relaxation techniques or just distraction can sometimes help.
Okay, so try all that first. If it's not enough, then you consider medication.
Exactly. Then you move to pharmacological options. The first-line treatment recommended in the notes are the non-ergot dopamine agonists.
Okay, those names again.
Examples listed are pramipexole, ropinirole, and rotagoding. They work on that dopamine system we know is involved.
Are there other types of meds used?
Yes, the notes also list anti-epileptic drugs, specifically gabapentin and pregabalin. These are often considered, especially if pain is a major feature of the symptoms. And then there are alternative options mentioned, but with a note of caution. Things like weak opioids, maybe codeine or hypnotics like benzodiazepines or Z-drugs for sleep. But these seem to be more for difficult cases or short-term use, not the go-to starting point.
And you mentioned a potential issue with long-term dopamine drug use.
Yeah.
Augmentation.
Yes, that's a really important concept the notes touch on for long-term management, especially with the dopamine agonists. Sometimes, over time, the medication can become less effective, or worse, you can get augmentation.
What's that exact?
Augmentation is where the RLS symptoms paradoxically start showing up earlier in the day, or they become more intense, or they might even spread to other parts of the body, like the arms. It's a sign the treatment itself might be making the underlying RLS worse in a way.
That sounds tricky to manage. When should someone be sent to see a specialist?
The notes suggest referral to a neurologist or a sleep specialist if the first-line treatments don't work well enough, if the side effects are too bad, or specifically if augmentation develops.
Okay.
And there's a very clear note. Children with RLS shouldn't be managed in primary care. They need to see a specialist.
Right. So it's a layered approach.
Yeah.
Lifestyle, fix underlying issues like iron, then meds carefully chosen, and specialist input for tricky situations. What's the long-term outlook? The prognosis?
The notes describe RLS generally as a chronic condition, meaning for many people it tends to stick around long term, but the severity can really fluctuate.
So it's not always terrible.
Exactly. And the good news emphasized in the notes is that with the right management, symptoms can often be controlled pretty well. This can lead to a big improvement in quality of life. Also, periods where symptoms just go away for a while, remission, are apparently quite common, especially in younger people who develop it.
And for the secondary RLS cases?
Well, as we said before, if you find and successfully treat the underlying cause, like fixing iron deficiency or changing a medication, the notes say the RLS symptoms might completely resolve, which again just hammers home why looking for those secondary causes is so vital.
That's actually quite hopeful. Manageable, variable, potential remission, maybe even resolution of secondary. Okay, last bit. Complications. What are the main downsides or associated problems listed?
The most obvious ones are sleep problems. Given when symptoms are worst, insomnia is really common, which then leads to being excessively sleepy during the day.
That makes sense.
And because it's chronic, disrupts sleep, and is just plain uncomfortable, the notes state RLS has a really significant negative impact on overall quality of life. And importantly, they also mention that people with RLS have a higher risk of developing anxiety and depression compared to people without RLS.
That link to mental health is really important to remember. It's not just physical.
Absolutely not. Think about it. Chronic poor sleep, dealing with these weird sensations daily, the impact it can have on your work, your social life, it all adds up. It definitely underlines the broader impact this condition can have on someone's well-being.
Wow. Okay, we've really unpacked these RLS notes from the basic definition, what might cause it, how it works, telling it apart from other things, who gets it, how it feels, how you diagnose and investigate, the treatment steps, and the long-term picture, including complications like sleep issues and mental health links.
Yeah, we've covered a lot of ground. It boils down to this brain-driven urge to move the legs, often worse at night, linked potentially to dopamine and iron, which really impacts sleep and well-being, but often has identifiable triggers or contributing factors.
Hopefully running through it like this helps consolidate it all for you, makes those key RLS facts easier to pull up during revision.
Absolutely. And maybe a final thought to chew on from all this. RLS really highlights how crucial it is to listen carefully to subjective symptoms, things you can't easily measure with a test. How do we validate that patient experience and use it effectively for diagnosis?
That's a great point. And if you are revising this stuff and looking for more structured help, check out the resources over at passthemsra.com. They've got loads designed for this kind of medical revision.
And for some free starter materials, you can also look at freemsra.com.
Brilliant. Well, thanks for joining us on this deep dive.
Yes, thanks for listening, and keep up the great revision work.